My name is Dr. Hakim Yusuf. I'm a consultant in intensive care medicine at Glenfield Hospital, Leicester. This presentation is going to be about pyrexia of unknown origin. Pyrexia of unknown origin is defined as a temperature higher than 38.3 that lasts for more than 3 weeks with no obvious source despite appropriate investigation. With regards to its etiology, you can classify pyrexia of unknown origin into 4 categories. You have the classic pyrexia of unknown origin, you have the nosocomial pyrexia of unknown origin, immunodeficient pyrexia of unknown origin, which is usually due to neutropenia, and HIV-related pyrexia of unknown origin. The classic pyrexia of unknown origin usually lasts more than 3 weeks, and there would have been evaluation of at least 3 outpatient visits or 3 days in hospital. Usual causes include infection, malignancy, and collagen vascular disease. Nosocomial pyrexia of unknown origin occurs in patients who have been hospitalized for more than 24 hours but have no fever on presentation admission. You need 3 days of evaluation to make this diagnosis, and common causes include Clostridium difficile enterocolitis. It could be drug-induced thromboembolic disease, especially pulmonary embolism, septic thrombophlebitis, including DVT, and sinusitis, amongst others. Immune-deficient pyrexia of unknown origin is associated with neutrophilia with a white cell count of less than 0.5 in the serum blood. You require an evaluation for at least 3 days, and common causes include opportunistic bacterial infections, fungal infections including aspergillosis and candidiasis, and herpetic viral infections. HIV-associated pyrexia of unknown origin usually has a duration of greater than 4 weeks if it has been evaluated in an outpatient setting, or greater than 3 days if it has been evaluated in an inpatient setting. HIV infection needs to be confirmed, and common causes include cytomegalovirus, Mycobacterium avium intercellulare complex, pneumocystis jirovecii pneumonia, or what used to be known as pneumocystis carinii pneumonia, drug-induced pneumonia, Kaposi sarcoma, and lymphoma. Infection is the most common cause of pyrexia of unknown origin, causing greater than 40% of all cases, and in some series an incidence of higher as 50% has been quoted. Of these, deep-seated and cryptic infections and abscesses are a common cause of pyrexia of unknown origin, but other causes include TB, uncomplicated urinary tract infection presenting atypically, endocarditis, especially subacute endocarditis, subacute osteomyelitis, empyema thoracis or empyema in other body cavities, prostatitis, viral infections including cytomegalovirus and Epstein-Barr virus causing infectious mononucleosis, parasites such as malaria, especially chronic malaria infection with organisms that have hypnozoites in the liver, toxoplasmosis, leishmaniasis, and fungal infections. Malignancy is the next most common cause of pyrexia of unknown origin, causing up to 25% of cases. This can be grouped into the hematological malignancies and the non-hematological malignancies. The most common of the hematological malignancies include lymphoma and chronic leukemia. The most common non-hematological malignancies include renal cell carcinoma, pancreatic cancer, colon cancer, and hepatoma or primary cell liver cell carcinoma. Autoimmune diseases form the next most common causes of pyrexia of unknown origin, and in some series it's been seen to cause up to about 15% of cases. Commonly grouped into this category include diseases such as rheumatoid arthritis, but this has been taken away as improved diagnosis of rheumatoid arthritis has made it less of a disease associated with this condition. Other diseases that have been well associated with this disease include Still's disease, temporal arthritis, Reiter's syndrome, systemic lupus erythematosus, polyarthritis nodosa, giant cell arthritis, and Kawasaki's disease. Other causes that are not categorized in the aforementioned categories include hypothyroidism, alcoholic hepatitis, inflammatory bowel disease, thromboembolism, either peripheral or central in the case of pulmonary embolism, but also drugs causing drug fever have been cited as causes of pyrexia of unknown origin. Common classifications include anti-tuberculosis drugs, antiretroviral drugs, antibiotics including penicillin, erythromycin and nitrofurantoin, ACE inhibitors, particularly captopril, and antiarrhythmics including phenytoin, procainamide, and quinidine. Now, in assessing a patient who is presenting with pyrexia of unknown origin, there's an approach. The approach starts with a very good and comprehensive history. First, you want to take a detailed history around the fever, what's its onset, and the pattern of the fever. Often the pattern of fever can actually lend you clues to what the etiology is. Intermittent fever often seen in diseases like malaria and septic phenomenon. Continuous fevers are usually seen in things like UTI, meningitis, and remitting and relapsing fevers are characteristics of diseases such as tick-borne viruses and brucellosis. Also, it's important to note the antecedent events prior to the onset of fever, such as trauma. An insect bite could lend you in the direction of tick-borne virus diseases, or recent travel could lend you to a diagnosis of thromboembolism, or could lend you to a diagnosis of a tropical disease that is not endemic in the area that the patient is presenting in. Dental extraction could be antecedent to subacute bacterial endocarditis. Associated symptoms such as chills, rigors, night sweats, loss of weight could lend to the potential diagnosis, especially with malignancies, especially when you look at things like loss of weight, chronic cough, and shortness of breath. Joint pain and skin rashes could lend towards a diagnosis of autoimmune disease and connective tissue disease. Bone pain and sore throat could lend towards disease such as infectious mononucleosis, and bone pain could actually trigger a likely diagnosis of osteomyelitis. It's important to look at past medical and surgical history, because that could point clues to conditions in which patients is taking medication in and which could be causing drug-associated pyrexia of unknown origin. A detailed drug history and allergy history is also very important, and a family history, especially history of the occurrence of autoimmune diseases, could provide clues as to what the cause of pyrexia of unknown origin is. A detailed social history is also very important to pick out predisposing situations to certain diseases such as TB, such as HIV, occupational exposure to allergens or to agents that might cause respiratory disease, and also history of recent contact with people who have certain infectious diseases such as TB. A detailed general examination is also required, but this is required to pick out clues, signs and symptoms that might indicate what the underlying diagnosis is. A detailed head and neck examination to look at sort of thickened temporal arteries in the case of temporal arthritis, iritis in the case of connective tissue disease and autoimmune diseases. Jaundice could point a clue to liver diseases. Rough spots could indicate infective endocarditis, and lymphadenopathy around the head could indicate lymphoma or acute leukemia. Looking at the arms, if you find drug injection sites, that could indicate IVDU use, which could lend you to a diagnosis of either hepatitis or subacute bacterial endocarditis. You may find rash, epitrochleal and axillary lymph nodes in lymphoma or lymphoproliferative diseases. The hands, you might find clubbing, cyanosis, splinter hemorrhage, arthropathy, and renal phenomena, which would indicate diseases such as connective tissue diseases, infective endocarditis, and chronic respiratory disease, which may guide you towards a diagnosis. It's really important to follow this on with a detailed step-by-step system examination, which may help to localize where the underlying disease is coming from. In the central nervous system, you want to look for focal neurological signs. In the chest, you want to look for murmurs, signs of pneumonia, TB, emphysema, and lung cancer. And in the abdomen, you want to look for hepatosplenomegaly, loin tenderness in the case of UTIs, and lymphadenopathy. Now, the history and examination may have to be done and repeated over and over again to actually qualify and gain more understanding of what the symptoms are and actually help with the diagnosis. Now, investigations are divided into different stages. The baseline screening test that all patients get, which actually help to guide towards the direction of how investigations should proceed. As a baseline, all patients should have a full blood count, erythrocyte sedimentation rate, urine electrolytes, liver function tests, blood culture, serum virology for the common viruses including CMV and Epstein-Barr virus, urinalysis and urine culture, stool culture and sensitivity, fecal occult blood, chest x-ray, and a MAN2 test. Now, after all these investigations have been done and results have been obtained, we can then guide you to the next stage of investigations. The second stage of investigation then depends on the findings in the first stage. Now, the findings in the first stage may actually lend you to actually want to perform a repeat history and examination, as I mentioned before, because then you might want to ask specific questions that are related to findings you found in your stage 1 investigation results. But in addition, based on that, you might want to conduct the tests such as serum electrophoresis if you're suggestive of a myeloproliferative disorder, CT chest, abdomen, pelvis, especially if you're thinking more of a malignancy or a deep-seated abscess or cryptic abscess, an autoantibody screen in the case of autoimmune disease, ECG looking for signs of myocardial ischemia or myocardial pathology, which could be indicative of infective endocarditis or Kawasaki disease where they have coronary atheromas. Bone marrow biopsy may be indicated if you're thinking of lymphoproliferative disorder, especially if your full blood count starts to, and ESR shows an indication that a patient might have lymphoproliferative disease. An LP may be indicated when you're thinking of meningitis as a probable cause. Temporal artery biopsy could be attempted in patients who have a history that's suggestive of temporal arteritis, especially if they have thickened temporal artery on your examination. HIV testing and counseling may be indicated in patients who have the required predisposing risk factors and in which you can't find any other cause. But obviously this has to be partnered with counseling to ensure patients understand the results and understand the implications of the results. Ultrasound abdomen would be really useful in evaluation of the hepatobiliary tree and also for looking at intra-abdominal collections which may occur in the form of cryptic abscesses, which may be the underlying cause of the pyrexia of unknown origin. Now, stage 3 investigations are informed largely to confirm some of the findings in the stage 2 investigations, especially if the results of stage 3 investigations are indicative but still not confirmatory of the cause of the pyrexia of unknown origin. Radio-labeled nucleotides are a good, or sometimes called white blood cell scan, are very good at localizing the foci of infection, and that might help to localize and find the source of deep-seated infection, especially like pelvic infection or deep muscle infections, which may not be easy to detect using other modalities. MRI brain may be useful in picking up malignancies, autoimmune conditions, and generalized inflammation. TTE or transthoracic echocardiography or transesophageal echocardiography can be used to detect bacterial endocarditis, and Doppler ultrasound and CT pulmonary angiography would be useful in picking up deep venous thrombosis and pulmonary embolism. Now, management of pyrexia of unknown origin depends on the underlying cause, but in a high proportion of patients, you actually don't find a cause, and this can be frustrating both for the physician and the patient. Actually, trying to intervene in that context actually has not been seen to be beneficial, and actually doing nothing in the patient who looks well but just has isolated pyrexia of unknown origin and no cause has been found is a valid management strategy. However, if a patient is really sick and there's an indication that a clinical assessment suggests it might be infection, even if you can't definitively find the source of infection, using broad spectrum antibiotics is is advisable, but this has been done in conjunction with infectious diseases specialists. The use of steroids in autoimmune and connective tissue diseases, they should be reserved for confirmed autoimmune and connective tissue diseases, not for suspected diseases, because in some cases of connective tissue disease, using steroids can be harmful. There have been reports of using aspirin in patients where no diagnosis has been made, despite extensive evaluation. However, there's no evidence for this. Surgery or interventional radiology to target and drain deep-seated abscesses is been identified as an intervention that may resolve certain deep-seated abscesses. Some abscesses are actually best left on their own, such as septic discitis, or which may be very hard to extend to, and you might just treat that with prospective antibiotics. The prognosis from pyrexia of unknown origin, especially where extensive evaluation has taken place and no cause has been found, fortunately has a favorable outcome, and the favor tends to resolve after 4 to 5 weeks. However, pyrexia of unknown origin due to malignancy unfortunately has a poor prognosis, and unfortunately most patients are presenting with late presentation malignancies where the outcome is poor and response to treatment is not as good as with the earlier presentations. Thank you very much, and I hope you found this useful in preparation for your MRCP Part 1.